Hello and welcome to our next session on health technology assessment regulation. My name is Giedra Peseckytė. I'm health reporter here at Politico, and I have a pleasure to moderate this panel. So we're meeting towards the end of the preparatory phase for the implementation of the regulation on health technology assessment, which aims to jointly assess clinical aspects of new treatments. I think it's important to highlight here that economic aspects of assessing drugs will remain the job of the countries. So in 2 months' time, starting in January 2025, assessment whether novel drugs are better for patients than existing care will be done jointly. This new assessment will first apply to cancer drugs, cell and gene therapies. It will eventually be expanded to other treatments as well as medical devices. So in this panel, I would love to see what has been achieved through those preparatory times and how are we ready to take off starting 2025. For this, I have a great panel with me over here. We have here Judith Fernandez. She's Deputy Director at HTA Department for French National Authority for Health. François Houillet, Director of Information and Access to Therapies at Rare Diseases Europe, EURORDIS. Maya Matthews, Deputy Director and Head of Unit HTA at DG Sante, European Commission. And last but not least, Martin Price, Vice President of Health Economics, Market Access and Reimbursement at Johnson & Johnson Innovative Medicine. So thank you all for making here, and I have a question for all of you. So there are many goals that this regulation will address. So I wonder, with just 2 months remaining before the takeoff, does it look that this regulation will address the goals to improve inclusiveness and transparency and increase predictability for countries and for the industry? Judith, can we start with you?
Sure. Thank you very much for the invitation, and good afternoon, everyone. So I think from the perspective of HGS, first of all, we do see the value of this mechanism to produce high-quality reports that will be transparent, impartial, and quite early in the project life cycle. So, of course, the value, the benefits of this regulation across member states could vary, simply because the level of maturity also between member states and in national HTA system can be different due to the difference of healthcare systems. But we do think that this regulation across the continent could help to accelerate the patient access to projects that have a clinical added value by increasing the transparency and more generally increase the global awareness on new projects. It's always difficult to address a question to isolate a single component into patient access, because ultimately national decision on reimbursement pricing are a multifactorial process. It depends on the HTA assessment, it depends on the values of the citizens, but it also depends on the willingness of the companies to actually submit a dossier for reimbursement and to engage in the pricing negotiation. So a bit difficult to always isolate the components of a single procedure, such as the joint clinical assessment in the acceleration of patient access. But it is one of the aims, because it will simplify the administrative pathway that is currently in place in 27 member states. And we do think that when we simplify, we contribute to accelerate the process.
And do you feel that you're more or less ready in 2 months to do that?
So at the end of the month, we will release the final guidance and procedure. We are also working, the Commission is working intensively to finalize the implementing act. It will be the end of the very intense preparation phase. We do think that we will be ready, that we will be as ready as possible, because this is a new framework, and we will start concurrently. The first step will be January 2025, but this is the beginning of a long journey of implementation toward 2030. And I think when I said as ready as possible, it's also because we are expecting and calling for health technology developers to engage with us, to submit letter of intent, to be clear on their pipeline, so we can also altogether forecast the future and the work program for the upcoming years.
Thank you so much. Maya, I would love to hear from you. What do you think about the preparedness? Because from the Commission's perspective, how satisfied you are with how the implementation is going, and can we expect successful takeoff?
Okay, thank you very much. And first of all, I want to thank you also for putting this on the agenda of the Health Summit, because as you can hear, there has indeed been a lot of flurry of activity over the last 2 years. We have a very long task list, but I would like to say the task list doesn't just fall on the Commission. As Judith said, this is really an innovative approach to policy making, because we have several partners in this. And so obviously the member states are our partners, but also patients' organizations. We have also clinicians that unfortunately, I think a clinician was supposed to join us today, but was not available, which is great because, and then of course the industry. So we're really, I think, entering a new way of policy making where we first have to define the role of the different actors, but then it's also a huge trust building exercise. And I would say that the last 2 years of preparation have also been a trust building period. And we have worked in the Commission, we facilitate this process, but we also ensure that the different actors are engaged with each other. So we have a stakeholder network, which again is the first for a regulation to actually stipulate a stakeholder network. It even stipulates the eligibility criteria for the members and the fact that it should be a type of consultative body. So it's really bringing in all the different actors that need to have a voice in HTA. The other area I said, which I think is also very important to mention, is that apart from the regulation, and I should have brought a copy because the regulation is very slim, but each article has a lot. We've been going through it, all of us, I think, intensely. And so we have tertiary legislation that we've been also having to adopt, and that we're moving quite swiftly on that. So 3 of the tertiary legislation have been adopted. One of them, I would say, is also groundbreaking in that it is a framework for the assessment of conflict of interest. This is the first of its type to have ever been adopted at the EU level. So the whole HTA regulation, behind it is a whole philosophy of how we're working together. Because I think, as you said, let's not lose track of the main aim of this legislation is really to support the member states in their decision making. And so many people ask, why is this topic in my unit? And I'm working in health systems. And why shouldn't it be in one of the pharma units? And my Director General, very early on when she moved the portfolio to my unit, she said, for me, I see this work as really contributing to health system sustainability. So we also look at it in that view, that this is a tool to really support the member states, but also industry, patients, clinicians, about developing evidence together, creating a high quality of evidence generation. So there's many aspects to it. Our task list is long, but as Judith said, we are going to start in January, and we're going to work together, and we're going to develop it further, and we're going to bring HTA, as it's known, to the EU level.
Thank you so much. I would love to hear from the patient's perspective. Francois, how do you feel about the preparedness of the HTA regulation, especially when it will touch on cell and gene therapies, something that is very important for rare disease patients?
I think since we've been pushing, waiting, and expecting this to happen, maybe we're not totally ready, but we are full of expectations. And when I think back to 2008, 2009, when we first heard about the European network of HTA, UNETA Joint Action 1, we all said, oh, great, very soon member states will be assessing our medicines and technologies jointly. How naive we were, weren't we? We know that nothing happens overnight in the EU. It took some more time, and now I think we have more realistic expectations from this cooperation. Another important initiative, which I would like to remind everyone, 2012, the European Commission attempted to revise the Transparency Directive. One issue we were having by that time, and I think we still have, is that not all member states were completely clear, open, and transparent regarding the information they were requesting from developers. So the 180 days delays were not respected, and some member states were asking last-minute questions to the developer because they said the 180 days delay only apply when we have all the information that we need, except that they did not explain upfront which information was needed from the developer. All this to say that this is the main expectation we have with this cooperation, that all developers will submit information in response to the request from member states all at once via the same system, making everything more transparent and maybe accelerating not the access, because that will remain a national decisions, but maybe the time to the moment decision makers are ready to make the assessments. So your question on advanced therapies, and we have an additional expectation. We know these therapies are extremely difficult to assess. And often what we have seen at the European level is that when you bring together the best experts, there is a process by which all experts try to leverage up their expertise and to take the best of their competences to really analyze the data, the evidence that they have, and provide an opinion or at least an assessment of the evidence that is there that can then be used by all member states, even member states where the expertise to assess these therapies is maybe less prevalent.
Thank you. Thank you for bringing this point. I think it's very important. Before moving forward, I would also love to hear what's the industry's perspective. We have here Martin, and I would love to hear from you from what you just heard from HTA body in France, from the Commission, how prepared everyone is and how industry is prepared for January 2025.
Yeah, I mean, it certainly is going to be a fundamental change to the way that we get information from ourselves to the member states. And I think that we're approaching this in a solutions-orientated mindset to work with other stakeholders to make it work. We have to make it work. So we're looking at how we can manage some of the areas that we're most concerned about. So, for example, we want to make sure we don't get too many PICOs. We understand we need to meet the needs of all member states, but by the time we receive the final PICO to when we have to submit, in the best instance is 100 days. So we really hope that we're going to kind of balance the need to address everyone's needs with a need to deliver within that time frame. So can we in the future perhaps harmonize our PICOs? That would be something that we would really like to try and move towards in the future. And I think if we can join up scientific advice in the future with a more unified approach for EU HTA, I think this will have the advantage as well of improving the voice of Europe in global R&D decisions. So I think there's a real opportunity there for us to leverage the power of Europe to make sure we have the evidence we need to make sure we can get access for patients. So that's something that we're wrestling with at the moment. And I think coming back to something that was talked about in the pharma legislation panel, for me, we know we have a problem with access in the region. So the variation across the European Union is a factor of 6, from the fastest to the slowest. And from our perspective as a technology developer, we really have to try and make a difference there. Otherwise, all of the extra work, all of the extra analysis, particularly up front and until this becomes business as usual, will all be for nothing if we don't keep the patient at the center and drive for less variation and quicker access, or at least quicker decisions, and then the pricing and reimbursement discussions can follow. So we're approaching it with optimism. I think there's great opportunity, but we'll have to course correct. I think as we go along, there'll be a few challenges along the way, but I think with other stakeholders, we're committed to make it work.
I think what I love about this topic that usually when I speak with people, they are all always optimistic and they really see the added value of it. Just quickly to ask you, Martin, are there any treatments from Johnson & Johnson that will go through the assessment next year, if you know?
We're possibly. I mean, this is the issue with drug development, is it's inherently uncertain. So we're still kind of evaluating which products in our portfolio will go through first, but we thought the ATMPs and oncology drugs will be first. So we're looking at within our pipeline there, but we certainly expect to have some oncology drugs going through in the first 2 to 3 years. But I don't think we'll be the pioneer, which is maybe no bad thing.
Yeah, I will go deeper on the pioneers and those who try to avoid the first being the first to go under assessments. But Judith, I would love to ask you, because as Deputy Director of HTA Department and French National Authority for Health, and also the member of the HTA Coordination Group, I'm sure you have the insight of how many treatments are expected to run under the joint clinical assessment starting next year?
So we are finalizing the work program for 2025 among the coordination group, and it will be submitted at the end of the month. So I will not disclose entirely the work program, just to give you so the incentive to look at our documents at the end of the month. I think we estimated a little bit how many drugs we are going to see and who are going to be eligible for GCA in 2025, mostly based on the assumption from the EMA. But we have to acknowledge that this is a bit difficult to predict with 100% of certainty the future. As it was mentioned, it's always difficult to estimate clearly when it's going to be submitted. And this is why also earlier I called for companies to submit their letter of intent. So it could also help us to forecast the work program so we can plan all together the first joint production.
Mm-hmm. Just another question for you. I wonder, did the French National Authority for Health need to upscale to prepare for joint assessments? Were you hiring additional people? Did you need additional training or anything like that?
This regulation will, of course, change a little bit our procedure. Because very concretely, when a company will submit a request for reimbursement at national level, the company will not submit again the data that were submitted at European level, but also the HTA department will not conduct again the critical assessment, the scientific assessment of the data, and we relied on the GCA report. So obviously this is a little bit change in terms of our national procedure, but we are preparing for many years now, so we do have internal trainings. We will also benefit from the capacity building tender that was signed this morning, but maybe Maya will quickly elaborate on that later on. We do see a need for capacity increase, for resource increase, because this regulation, when we work together, it's always with the intent to elaborate very relevant, very impactful report, but of course it requires energy, it requires time, it requires expertise. So we do hope to increase our capacity and resources in the upcoming years, but regardless of the final numbers, we do plan to be active in the production of joint clinical assessment and joint scientific consultation, both for pharma and medical devices.
Perfect. Thank you for this answer. I think it's important to know that France is really up to speed with this, right? With technology assessments, you're one of the leaders in the bloc. And I had a chance to speak with Estonia Center for Health Technology Assessment. So, for example, they have only 3 people working on health technology assessments in all Estonia. So, you know, in addition, they sometimes contract external writers and researchers, but in the end, it's only 3 people. So I was told that their capacity is a challenge at the moment, and it could be said that this is related to funding, at least what they told me. So I would like to turn to Maya, and like, what do you see in other HTA bodies across the European Union, how prepared they are, and won't the first assessments fall like agencies as you did?
Yeah. No, thanks for the question. I mean, I think that's what makes this quite interesting, because what we're doing is we're actually trying to kind of lift everyone to a high quality assessment. So, of course, there are countries like France and Germany and Netherlands and Spain that have, a very developed HTA system. But the beauty of doing this at EU level is that we have the subgroups, the 4 subgroups that are looking at the 4 kind of workflows, and the members are from all of the member states. So it will be part of it will be, it's not necessarily capacity building per se, but it's learning from the experience. So you will have 2 assessors from different member states, these experts that will be doing the joint clinical assessment, but then they will be discussed amongst the members of the whole subgroup. So we're hoping that with time, you will have more assessors, more interest from other member states. I think the other thing that I've seen is that because this is at EU level, it's leveraging also more political commitment at the national level, because I think that's often, we maybe underestimate the power of putting something at the EU level. So there are member states who are quite keen to engage, but they say, like you said, from Estonia, that they have a few people, and because of the staggered approach, we will not be assessing all of the medicines that will be coming through the European Medicines Agency. So there will have to be a balance. Of course, the national assessors will do then the national medicines, but they're still engaged in the process. And as Judith mentioned, part of this is capacity building. So we've just signed with a group of HTA bodies led by the Italian Agenas, a capacity building tender to really drill down and focus on this new methodology that we've co-created together, so that there'll be more assessors available to do the joint clinical assessment, but as you said, also the scientific advice, as we call joint scientific consultations. We also have 2, because I think, I'm sure you will speak about this more, but also for patients, this is very new. There are many countries in the EU that do not consult patients. So this is something now that we are kind of creating this momentum at the EU level, that patients will be systematically consulted on all of the joint clinical assessments and the joint scientific consultations. So we have 2 projects through the EU for Health program, and Eurodis is involved in one of them, and EUPATI and European Patients Forum. To really work as well with the patients. So, as I said, we're really addressing, we're trying to bring the best of different models, and we're trying to bring this together into this new EU HTA framework.
Mm-hmm. Thank you so much for that. Are there any funds from the Commission that goes directly to the HTA bodies for their preparation, upskilling, or?
So, as I said, there's this new capacity building tender, and then we have launched a framework tender to work on the joint work, to fund the joint work that will be necessary to produce these reports, and that's currently being evaluated by our executive agency.
Thank you so much. Just to check, Martin, are there any concerns from industry side on the preparedness of those people that will be running the assessments?
Yeah, we're a little worried, I would say, about the readiness within some of the member states. So clearly some are further ahead, some are less well prepared, I would feel, which is kind of what you would expect to a degree. But I guess, particularly in the early years, I worry a little bit that those countries that go very early might be a little bit delayed. And I'm also a bit worried that those slower countries are not looking deeply enough about how they can fully leverage the JCA to reduce duplication, to go a bit quicker. And I also sometimes wonder, sort of maybe a bit provocatively, whether there is, in some countries, a real desire to speed up anyway. Because delay in HTA is a form of cost containment. It's managing the budget. So I think we're going to need to continue to learn as we go along. And I think we're also going to need to, and Natalie Moll talked about this earlier, have that kind of shared objective and collaboration to really try and reduce variation and to make sure we get those vital new technologies to patients as soon as we can. Because often for many of these diseases, time is life. People cannot wait. And I don't think we talk enough about the life years lost while patients are waiting to receive new treatments that have been approved by the EMEA. So I think there's a huge opportunity here, but we kind of all need to work on it because the root causes of delay are many and they're multifactorial. But certainly having the evidence synthesis done quickly, efficiently, once, it should be an opportunity, I think.
Francois, I would love to bring you in here. We're talking about how countries are prepared, and I wonder, is there a concern over how the countries will include reports in their working procedures, and how will this change the national practices?
Yeah, on this, we think that those who will change the way they work to adapt and to take the best of the European reports, the European Joint Clinical Assessment reports, will be the best place to make all the efficiency gains and to really facilitate their own appraisal, their own national procedure. Those who will not change profoundly the way they work, they won't be familiar enough with the European report, they will have difficulties to incorporate the results of the European report in the way they work. Just to make a comparison, at the EMA, one agency that changed completely and that aligned completely the way they work on the European Medicines Agency was the MHRA in the UK before Brexit. And because they had exactly the same working instructions and methods, they were performing 20% of all the scientific evaluation at the EMA because that was exactly the same work, but they had changed the way they worked. And we hope to see the same changes and adaptation in many member states to take the best of the GCA reports. And we already see efforts from national HTA bodies that haven't been working a lot with patient organizations to initiate working relations. It will be important to organize meetings at the national level to discuss which are the most relevant PICOs in the country that could feed the survey that the European cooperation will conduct. So there are adaptations, there are changes that are needed and still in progress. We'll see if we can compare different approaches and benchmark which countries in particular have adopted the best and most effective ways to engage patients. And maybe just to add a few more roles than the ones envisaged in the regulation, or they are, but not always clearly visible. The most important contribution patients could make here are to define what are the unmet needs of the patients, which technologies are particularly needed, and here they could naturally work with a subgroup on emerging technologies to flag which products are of particular importance and why, and which ones should benefit from joint scientific consultations because we cannot afford failures in the development of some technologies. And at the end, when a product is approved but with a high uncertainty and confirmatory studies are needed to reduce that uncertainty, we also need to work with patients and to have patients explain what else could be measured that would document the actual benefit of the technology in our lives. So that used to be called the post-launch evidence generation. But here again, at the two extremes, these are extremely important roles for patients and their organizations. Plus, to take part in the assessment, in the joint scientific consultations. And assessment means the scoping and the review of documents. Ideally, we would like to contribute to the assessment itself. There are patient experience data to come, patient preference solicitation studies, many studies that could inform on how patients see the benefits of the technologies, where we still need to work with the HTA Corporation and HTA bodies on how to submit this evidence.
And all this that patients can bring to the table, right, in helping to run this process of assessment smoothly and actually more directed, better. Do you feel that you're involved in the framework? Under current framework, you can express all these things that you were just mentioning? Well,
there is the HTA stakeholder network, where I think there are 15 patient organizations, but it's enlarged. More organizations are joining, plus healthcare professionals, plus industry, plus academics. Due to all the work needed for the preparation, maybe we haven't made the best use of this stakeholder network yet. We meet once a year, and we can only hope in the future that we will establish more specific and dedicated working groups to work on specific issues. For example, all patient organizations could join together and share best practices on how to find the patients who will be invited to contribute to the HTA, how to prepare them, how to explain them what the procedure is about, to guide them through the documents they will receive. Some of us are very well prepared for that, but for some it's new, so we need to exchange, and we need different working groups to share different experiences. So this will come with time. For the moment, we understand that the priority is the launch of the cooperation next year.
Thank you for sharing this. It's true that the topic is really technical, and probably for patients it's not easy to have this additionally to. So I just would like to. I will touch again access a bit later. Not access, sorry, the involvement. But what we were talking before, basically that having one HTA highway is making Europe more attractive also for industry, right? It's easier. So currently the promise is to cut 27 duplicated processes across Europe and speed up access to medicines for patients, hopefully. So back in May, when I was writing a story on HTA, Mihai Rotaro, Market Access Director at FPIA, told me that in the grand scheme of things, it's certainly a good idea. However, this year and next year are uncertain and maybe scary. So, Martin, are next year scary for the industry, and are they still uncertain? Are you still lacking some information?
So, I mean, I think we're getting more certain as we get closer to the date, which is a good thing. So I think we know more than we did in May, and a lot of work has been done on the regulation and stakeholder engagement and lots of dialogue. Of course, we will learn more when we move into an implementation phase. So I think there's naturally going to be uncertainties. I guess the thing that I'm reflecting on is, I think it's quite brave in some ways, because the first technologies that have been selected are ATMPs and oncology. And my many years in sort of patient access has told me these are the sort of two biggest problem areas because of the nature of the technology, uncertainty in the evidence, and the fact that, you know, in some cancers, we have such great data that patients are living for many, many years. And therefore, by the time we've completed the trial, we have quite a lot of uncertainty, and certainly the same can be said for ATMPs. So how we manage that uncertainty, how we address gaps in the data is going to be incredibly important. How we use indirect treatment comparisons. So I guess for me, it's now not so much how the process will work, but it's the application of that process in the real world. And I think that's where we're going to have to really work together, because the information will be imperfect, particularly for these first set of technologies. How are we dealing with that, and how are we going to be able to make decisions at the right time whilst managing the uncertainty? And I still haven't quite understood how that might work.
Judith, we're hearing some of the concerns that industry still has. How do you think we can help, or is there enough information you think from your side that they have already available?
So we did produce many methodological guidelines, but of course it will become clearer with the experience and with the production of joint clinical assessments. I think obviously we acknowledge that this guidance, these expectations are grounded in high standards on evidence-based medicine, and that they also need to respect the need from all the member states. So we do understand that the expectation is high. It's also high for ourselves. We hear the need for nuances, for discussion on uncertainties, acceptance of lower evidence. This is something we are open to discuss. But we also need to acknowledge that this specific area is really highly dependent on the national competencies, because accepting uncertainties means that we accept to reimburse, to set a price according to the data that we have and the data that we don't have. So really this management of uncertainties, this planning of the future and how to address these uncertainties is somehow very grounded in the national competencies to decide whether or not we accept this product with this condition and how much we are willing to pay from our health insurance. So there is a room for discussion in the European framework, but we also need to be conscious that at the end it needs to remain a system that is objective, that is that can be reproduced, and that will need to respect ultimately the decision from the member states.
Thank you for sharing that. I think it's no wonder why industry is concerned as well, because having kind of scoring bad under the new report might give a weak hand when they start conversations about pricing and reimbursement. And I think there was a lot of talks on single-arm trials after the guidance was released. I wonder, Maya, if you would like to comment on this. Was the concerns legit?
I think, I mean, it's part of the whole discussion about evidence, and then we're trying to drive the evidence. We're trying to increase the quality. I think everyone agrees that this is, what we're trying to do. We can't do it overnight. So I think, as Judith was mentioning, the guidance that the coordination group is developing is really the state of the art of the time. And they are open to looking at how it can be further developed on the basis of what we see coming from the next, the joint clinical assessments and the joint scientific consultations. So I think it's also, there's a lot of anything new, anything new, we're setting up something new. Of course, everyone has concerns, they would like it in a certain way. But I think, again, we shouldn't lose sight of the fact that this is quite extraordinary what we're doing, because we're really bringing expertise together. This is why, I guess, we're embarking on this very complex project, because there is real EU added value there. Because up to now, let's be frank, maybe these reports are only available to several countries. What we're doing now is providing the same evidence to 27 member states. And I think that's something that should be applauded, because what we're doing is really providing this level playing field. And then, as Judith said, then it's up to the member states to see how they want to then further craft the joint clinical assessments and what they need. One thing I think that's important is to be aware that each national health technology assessment will have to have this EU report attached to it. So you can't ignore the report, and they have to also, the member states in the regulation, have to explain how they have used the report. So when some people were saying, oh, this is just for some member states, they're just going to ignore it. They can't ignore it. This is really trying to push everyone to look at the clinical evidence, but then they will make up their own decisions. So it's difficult, it's nuanced, it's not easy, But I think that if we all kind of work towards looking at where we can make, like you were saying, that where we can get better things, this is a long journey.
Mm-hmm. Yeah, thank you for bringing this up. I was actually wondering to ask, how we will be looking at the implementation, how we will be following, and I think this is one of the examples that you just brought up. Françoise earlier mentioned the stakeholders network, so I would like to hear also from Martin, how do you feel involved in this whole creation of HTA? Do you feel heard? Yeah, your thoughts on that.
Yeah, look, I think we've, as a company, we've been very active through FPIA and through the working groups that have been looking at the various elements from methodology, etc. And just on that, I think, the one thing that we're still trying to really get heard on from a methodological point of view is the use of indirect treatment comparisons. So, if I mentioned earlier, if we have multiple PICOs, we'll probably have 1 or 2 trials. To satisfy all of the PICOs, we're going to have to do evidence synthesis. And if you look back historically at the joint actions on HTA, there was a very low acceptance of indirect treatment comparisons. So we want to feel kind of, I guess, a bit more heard to say, we're going to be walking into a big problem here if we have multiple PICOs to satisfy. And then when we try and address it through evidence synthesis, we immediately get it discounted as being low quality evidence. That's not going to help anybody. But I think generally, we feel like we've had a voice. I think the cooperation amongst companies at FPIA has been excellent. And I think, Maya, you can maybe talk about how you feel it's been from your side. But have we got everything we want? No. Did we expect to? No. But I think there are still a few little areas that we would like probably some movement on, or at least to be heard. But let's not view the conclusion of the implementing acts and all of the regulation as the end. That's the start, and we need to continue this dialogue as we learn and go forward here.
The number of PICOs that was just mentioned by Martin, Judith, what's your take on that?
I think, again, this is a learning process. I think we all are very committed, and I think we need to acknowledge also the high level of engagement commitment within the coordination group. I think we are working together to set the minimum number of PICOs. We often see that we speak the same language across HTA bodies, and I think this is also why we supported this voluntary cooperation since that started almost 20 years ago, because we share the same values, we speak the same language, but sometimes we use different words to express the same meanings. So we need also time to acculturate and work together, but we shouldn't be also too focused on the numbers, right? These PICOs are there to set the scope, what we expect in terms of data. It settles what we expect the company to submit and try to generate. This is not an invitation to generate low evidence data if there is no data. The company in this case should justify that there is no data to address this PICO. And then ultimately, at the national level, we will conclude on whether this is acceptable or not acceptable. But this type of conclusion based on uncertainties, this is already our daily activities at national level. So again, I think we are putting a lot of emphasis on this number of PICOs, but it doesn't mean that we absolutely expect concrete evidence for all of the PICOs. We often know that all our requests, all of our expectations will not be addressed. And that ultimately we will have to base a decision based on the gaps between what we expected and what we concretely have.
Martin, is it reassuring? Is it like, so that then we don't have to do so many?
Yeah. Well, let's see. I mean, I think I think, you know, in a number of countries, it is acceptable that we address gaps in the randomized trials with indirect treatment comparisons. In other countries, not so much. So Germany don't like it. UK, I know outside the EU, but UK, nice. They're more amenable to it. So we have this kind of variation, and I think what we would like to see is a bit more harmonization, because as a healthcare technology developer, you know, when I talk to my global organization, unpredictability is not a good thing. And having to satisfy multiple different tastes, if you like, from different countries, it becomes incredibly challenging to try and design our clinical development plans in the right way. So the way I look at it is indirect treatment comparisons can help satisfy evidence gaps where it's not possible to include everything in the trial development plan, and it really isn't. But then we need a kind of acceptance, and the way I look at it is, you know, a bit of pragmatism. If everything is going in the same direction, it probably tells you something. You know, if you have huge uncertainty, of course, you need to reflect that. But I think if we're overly purist about it, it's not going to help decision making. I guess that's my perspective.
Francois, you want to come in? Yeah.
To add that the PICOs should not come as a surprise to the developer 120 days after they submit their letter. Ideally, there would have been joint scientific consultations upstream to discuss which evidence would be needed, would be adequate for the HTA bodies in different countries to assess the technology. And I think we all regret, and HTA bodies the first ones, that there are not enough assessors to perform all the scientific consultations that we need. But if we really want to reduce the cost of medicines, we need to work with industry to reduce the risk that this development fails. And only scientific advice and joint scientific consultations can reduce that risk significantly. So this is a must. We really need to have the resources to have as many scientific consultations as needed, so that adequate evidence and high quality evidence are submitted to HTA bodies, and then that would smoothen the process.
Do you think there are enough joint scientific consultations currently foreseen, or you would like to see more of them?
I understand that there will be 5 for medicines and 5 for medical devices next year, to be compared with 600 to 800 at the EMA. So there is a gap which is enormous and not satisfying. Luckily, at least for priority medicines, the EMA can invite HTA bodies when they have scientific advice, so which adds to the scientific consultations. But that's really a weakness of the HTA cooperation if we cannot increase the capacity of the agencies to provide these consultations.
So I saw everyone nodding their heads while you were talking about it. Any final thoughts from you, Maya, on this one before we close the panel?
Yeah, no. For me, it's. I think it's interesting because we've touched on these 4 work streams that we're working on. So the methodology, the joint clinical assessment, which is now, as I call, the jewel in the crown, because that's really what everyone is focused on. But it's very nice that the panel have also mentioned the importance of the joint scientific consultation and this emerging health technology. So in an ideal world, 10 years down the line, all of these will seamlessly meet together. But in the meantime, we're doing this all at the same time. And so we need to be patient with each other, I think, but also optimistic that together we can really try and drive this process, so that I hope that all member states will really be able to use and to basically address the main point, which is to try to have their sustainability as well, and for patients to get the medicines that they need.
Well, thank you so much. I think each of you brought really great insights to the topic. And what is clear, I feel like everyone is optimistic about it. Even there might be a bumpy start. Everyone is willing to work on it. So let's end with this optimistic note, and editor Helen Collis will take the stage afterwards. Thank you so much. Thank you.
Great job, Guidra. Well, thank you so much for joining us today. We're just drawing a close to the first day of our Politico Healthcare Summit. And I hope you can agree with me that it's been a day rich with really great discussions on some of the most pressing issues that are facing countries, their leaders, politicians, health workers, and patients today. I just want to touch on some of the things that really stood out to me. Stella Kyriakides, our Health Commissioner in Europe, spoke strongly about tackling health inequalities and said that access, affordability, and availability are not an either-or decision. The ECDC chief, Pamela Rendi-Wagner, said we should prioritize AMR, that's antimicrobial resistance, vaccines, climate change diseases, but she said there's a real need for trust to implement measures in Europe. We had a really lively debate from a group of MEPs on the stage who suggested that Oliver Vaheli is likely to get approved. As MEP Steiner Bosse said, if not him, then somebody else, and we'll have to start again. Equal access to healthcare again was a hot topic for the MEPs as well. We heard calls to think about spending on healthcare as an investment instead of a cost from Francesco Colombo at the OECD. And she also had said that Europe's health systems are underprepared, underfunded, and understaffed. This afternoon, we had a really engaging discussion on the pharmaceutical legislation with representatives from both the Polish and Danish health ministries showing just how divergent the positions are on this legislation and how tricky it is to find agreement. And we had a panel that was hopeful to see a draft Critical Medicines Act text within 100 days of the new commissioner starting, while also at the same time setting out the complexities of solving the drug shortages issues. And finally, a great snapshot that Guidra moderated on where things stand with the launch of the new health technology assessment, implementation of it from January. Some concerns raised about member state readiness and a need for capacity building in smaller countries, but I think as Guidra summed up nicely, there's also a very optimistic note about it too. That's it from today. I'd like to thank our sponsors once again for making this happen. Our leading partners were FPIA and Sanofi. Our presenting partners were Daiichi Sankyo, Gilead, Johnson & Johnson, MSD, and the PPTA, and our networking partner, Intuitive. We now have a happy hour reception for those of you who wish to join us from 6:30 from now until 6:30 in the main networking room. And we resume everything again tomorrow on topics including prevention, preparation, and protection. And the afternoon will dive into next generation healthcare. Have a wonderful evening. Thank you.
United in diversity. We are very heterogeneous in our opinion.
If we do not renew our partnerships with the rest of the world, Europe will not be relevant.
We can make it if we are together as Europeans.
Do you genuinely believe that countries will manage to reach these very ambitious targets?